documentation in musculoskeletal physiotherapy. The talk will be delivered by Dr. K. Ganesan, sir. He is very well known in the annals of physiotherapy education all over the country. But just to mention for those who are joining for the first time or who don't know much, I would like to tell Dr. K. Ganesan, he's a sports physiotherapist with more than 2 decades of experience in the field. He's a certified instructor in Pilates and kinesiological taping. He has conducted 200 plus workshops all over the country on Pilates, taping, balls, bands, tubes, and fitness. He's currently heading the Department of Physiotherapy and Sports Medicine in Ortho-1 Orthopedic Super Specialty Center at Coimbatore, Tamil Nadu. Sir has also served as a team physiotherapist for Chennai Cheetahs for the World Series Hockey and Chennai City Football Club League football teams. He has been associated with various sports clubs, eminent and elite athletes, individual sports persons at grassroots level and as well as to the top professional levels. He has served as a chairman board of studies also and also as a board member the Department of Sports Sciences at Ramachandra Medical College, Chennai. He was chairman of board of studies at Pandit Ravi Shankar Shukla University, Raipur before also. His key area of work is in sports physiotherapy and musculoskeletal physiotherapy with special emphasis on ACL, shoulder rehab. He is a clinician by hand and he is an academician by heart, because we know very well that going through his illustrious career and experience, he always loves to learn and loves to share his expertise and knowledge with all of us. So this is our privilege and honored to welcome again Dr. K. Ganesan on this forum on behalf of Team Physio Inculcators. And again, it is a coincidence that today 2 months are being completed when the Physio Inculcators started their first session on 15th of May. The session on 15th of May was taken by Dr. Himanshu Sharma as the resource person. And since then, he has been serving as the host for all the webinars. And today is 15th July. Team Physio Inculcators has conducted around 66 webinars in these 2 months without any break, with 2 panel discussions, 1 symposium on cancer rehabilitation, and planning some other more events in the coming few days. So our heartfelt gratitude to all of you for joining all of us. It is our just a humble effort to create knowledge sharing, and people like Ganesan sir and all the resource persons have been joining out without any interest other than sharing the knowledge. So hats off to you and heartfelt gratitude to all the resource persons. Today is also the World Simplicity Day. So 12th of July is celebrated internationally as World Simplicity Day, and it is a great apt day for introducing our today's resource person. He is a very simple and humble resource person, Dr. K. Ganesan, because he always loves to learn and loves to share his knowledge. So without wasting much of the time, I would like to welcome Dr. K. Ganesan on the board. Heartiest welcome, sir. Over to you, sir. Thank you.
Good afternoon, everyone. Thanks, Harsh, for inviting me again. And Himanshu, again, a great job. And nice to know that this forum has been doing so well. And I can see the quality of the work and the number of speakers and the topics what you have been doing. So nice to know that I have few of my friends are also here. Hi, Jaban. I think Ramakrishnan is also there. Amrita is there. So nice to again catch up with you guys. So I think I can do my screen sharing, right?
Yes, sir. Yes, sir. Yes, it's visible, sir.
Okay, it's visible. Okay.
Yes, sir.
So today's topic of mine is on exercise prescription. I've tried to make this topic a little interesting from the clinical perspective, and for a revision point of view, it will be there. So I hope I can deliver what I'm planning to put on. Okay, so this is something of a quote which I use in all my teachings to tell people that the general perception with the medical community as well as the patient community is they always want to find which is a good exercise, or is this the exercise for weight loss or for my injury and all those things. So understand that there is no good or bad exercise at all. It's only the right choice and the right form of exercise. Now, some people are biased with gym, so they don't do yoga. They want only to do the gym-based exercise. So these are few perception of what people look into, thinking that how an exercise format is done. So understand that there is no bad or good exercise. It's only the selection of the exercise and how you are going to perform. Okay, so exercise prescription. Now, when do we prescribe exercise? Now, you need to know why you are going to prescribe an exercise and what is the outcome you are going to look at. Now, when people do research, they say your effort and outcome has to be there. So when you plan an exercise, you should know why you are going to give this exercise and what is the outcome you're going to look at from this. So if you can tell me why you are doing an exercise and why it is beneficial, then it is a good exercise. That means what? As a therapist, I am going to be aware that why this exercise is done and what is the benefit it is going to be done. So in our profession, exercise is mostly prescribed for pain management, for muscle activation, to restore passive range of motion or active range of motion. When you want to teach somebody a good pattern of movement or the correct way of movement, then strength training in rehab. So this is clinical based rehab strength training. And then fitness and strength based rehab is for something who is going into a sports or going to be gymming or doing any other activities, and then becomes your sports specific. So these are your, yes?
Sir, excuse me, sir. Good afternoon, sir. Sorry to interrupt you. Sir, I would like to request you. I think your screen is not in the full screen mode. Can you please, because we can see two slides together. One is smaller slide, one is bigger slide. I think next slide is also visible there.
Okay, just a second.
Yes, sir.
Just a second, just a second.
Okay, okay, no issue, sir. I think you are trying resharing.
Yeah.
Okay.
Can you now can you see one screen? Himanshu?
Yes, sir. One screen is there now. Now that is absolutely fine, sir.
This is okay, fine.
Yes, sir. Thank you, sir. Thank you very much. And again, apology for interruption.
Oh, not at all. So the basic prescription for exercise is these are the things. So why do people need an exercise is basically to be physically active and get about their functions and perform their activities. So if you look at our range of motion or movement of people for physical activity, first thing is they need to have activation. So that is basically the required muscles to function. Then passive range of motion, active range of motion, flexibility, strength, and all these components will help you in a functional pattern. So our initial classification of what I said exercises can be that these can be exercises where in our rehab setting where it is more of pain, muscle activation, joint stiffness, weakness, and movement pattern. Whereas when you go functional and strength, it can be your strength training, functional, and sports specific. Now, what are the principles to consider before you plan an exercise? So first thing is we need to know what is the primary function of the muscle. We all know that muscle has got a primary function and a secondary function. So we need to know what is the primary function. So it's basically the primary function you want to train or the secondary function you want to train. Then know whether it is a one joint muscle or two joint muscle. Because if you're going to have one joint muscle or a two joint muscle, then there is going to be an active and passive insufficiency coming. And if you see, all our joints in our body will have a one joint and two joint muscle. So that is going to differentiate and make our alterations in the range of motion what is expected. Then your range of motion will have to have individual consideration. That means some people can be hypermobile, some people can have stiffness, or some people can have a bad posture. So that time you cannot go with your conventional thinking, okay, there is the range I need to come up with. Then if you know the nerve supply, it is still very good so that you know whether there is any nerve involvement in the motor component. Then the amount of pain if they have, what position you are going to start your exercise. Would you prefer him to start at a supine lying, prone lying, side lying, sitting, standing? Then what you want to do as a open kinematic or a closed kinematic chain exercise. So before you start, you need to take these into account. Then what are the biomechanical principles you need to take into account? So axis and plane is the basic definition how we look at our human body movements. But once you are going into functional, we are not going to be very precisely doing axis and plane, but we are going to do variations. So if you are going to do a shoulder flexion, which is going to be on a frontal axis and a sagittal plane. So you can have variation that if he is going to do at 45 degree, that is going to be slightly off the specified axis and plane. But that can be a progression. Then we need to know levers. We have the first order, second order, and third order lever, and they are fundamental that muscle can take, or the mechanical advantage that movement is going to have. Now, how is this going to help me in exercises? How I can progress with my resistance. So when I add resistance in short lever, long lever, how it is going to load the muscle. Then need to know the end feel when you assess, because as an exercise program where you are trying to go and do a range of motion exercise where you might have to do some mobilization or active mobilization exercise program, the end wheel is required, and tissue tension. Now tissue tension is something we have to teach the patient what they need to perceive, because that will give them an indication that they are going to exercise in the right way. Now, sometimes a tissue tension is perceived as pain for the patient. So we need to tell them how do you differentiate. Now, when you are going to try and increase the range of motion, the patient will try to feel more of pain. He will tell, I feel pain. So what we can explain them is when you do a calf stretch, there is going to be a pain on the calf muscle, but that is going to be followed by a stretch feel coming from the tissues. So we need to tell them differentiate, because at the phase when we are going to give them exercises, with where there could be pain. So this differentiation will have the component how the patient will be able to progress the exercise, knowing which is a good pain and a bad pain. So exercise principles, what all we need to know. What is the aim of the session? So when you have the patient with you at your session, you need to have a specific aim. Okay, what am I going to do? I'm going to just assess, look for the quality of the movement, or I'm going to look at how he can do the strengthening exercise. So you need to have that. Then whether your session is going to be therapist assisted or equipment based, and whether you're going to give exercises which is based on short lever or long lever, and what are the assistive devices you might need for this patient. So you might need to use a cane, you might need to use a towel, you might need to use a band, a CPM machine, those things. Then coming on to 1RM and 10RM. Now this is basically required when you go on to the strength training. So when I go into strength training, I will explain this in little detail. Then we need to plan the frequency, intensity, and time. This is basically a principle for fit principle where we give for exercises how much days they need to do, intensity, and time. So I'll go that little later. And quality of movement. Now, defining quality of movement is like when you do a particular movement, you should be able to do it at the particular axis and plane without any trick movements, and recruiting the appropriate muscles without using any abnormal pattern. So that will be your quality of movement. Then comes your documentation. So how you are going to document your exercise session in terms of your frequency, notes, key notes like, okay, this is the mistake you're doing. Those things also has to be noted. Then comes your review. You need to plan when do you call your patient for review. Okay, so we have this guy trying to do a exercise. So I am asking, what is he strengthening? Now the answer will be that he is strengthening his hip muscles. That's the gluteus maximus. Okay, now consider stability and mobility. So whenever I do my exercise plan, the first thing I try to do is, okay, what am I trying to get better for this patient? Whether it is the stability or it is the mobility. Now this is the basic fundamental what we want our patients from. Whether he needs to improve his stability or mobility. So when you move it, you want to make sure that yes, it is deeply put it on the ground and it can stay. So stability based exercise have to be graded by mobility. So if I can push my axe about 1 feet, it can be. So that means what is flexible for 1 feet, but if it goes to 3 feet and feeling to things, so mobility when add stability, it also now have joints work on single plane or 1 degree of movement, we call them. Some joints work on 2 degrees. So we always have to plan our exercise. We start something on the safer one and then progress to the other sides. Then comes the open kinematic and closed kinematic chain exercises. Now, open kinematic chain exercises are mostly exercises more required on the lower limb because upper limb. Open kinematic activities are more shoulder, elbow, wrist based activities. Now, if I have a patient with wrist, elbow, or shoulder fraternity, what is the pain management you are looking at. So if it is pain management, that means it can be because of unknown source, or that is a micro trauma and followed pain. Inflammatory management is there is an acute active inflammation available at the localized area. So then I can choose whatever I want to use, whether it could be a modality, traction, soft tissue mobilization, joint mobilization, dry needling, or taping. So inflammatory, again, you can have cryotherapy, ultrasound, I can use taping, and even modality. Now, when it comes to exercise prescription, we try to differentiate the different part of the body, what we want. And then for range of motion, we start with passive, divided into open kinematic, closed kinematic. Then we add a balanced proprioceptive plyometric. Then your fitness based is there, face EMG, because we have the equipment. We also use that as an evaluation tool and a prognostic tool. Then we have fitness. Back to sports is people who have injury of sports, and how do we plan them to get back to sports. And then sports specific evaluations, posture analysis. So these are general things in a prescription form which I can use for an exercise prescription. So a lot of the time we have this misconception by the patient community and the sporting community, not knowing the difference between rehab and training. So they will use different terminologies to tell, okay, I am under rehab. I am under rehab in the gym. I am doing rehab in the physio clinic. So traditionally, if you see, both are having the same components. So the aim is both to improve the function, increase the capacity, reduce this. The only differences is in rehab, we are more clinical based, looking at the subjects where clinical relevances are there. So there can still be a phase of pain, slight restriction in range of motion, and deficits in the strength. Whereas if you're going to go on to the training, we are looking at somewhere there is very minimum pain or no pain, and there we are trying to load and push your body to improve your desired performance to whatever level you want them to do. Okay, this is a simple guide rule I use for people who want to know how much reps and pain. So usually when you do too little, it is of no use. But when you do the appropriate number of repetitions or load, that is the most beneficial one. And if you use too much, again, that is not going to help them. Now, to make it a little more clarifying, now this is a common pain measurement scale everybody is aware of. So we ask the patient from 0 to 10, what is your pain? Now, if I have a patient who says, I have shoulder pain and I have pain increasing on movement, we need to score his pain as a general. So he might say my pain is around 5. And when you ask him to do a movement, let's say flexion of the shoulder, he might say my pain is around 8. So you need to score shoulder overall pain is 5, and on flexion it is 7, and abduction is again 5. So when you give this different scoring, it is going to help us how to manage your plan of exercise. Now, the similar scoring is also used for exercise plan from effortless to maximum effort. And if you see, ideally, if you are going to do a strength training base, it has to be on this zone of moderate to extremely hard. Whereas for cardio, it has to be from light to hard. This is just a zone you can educate the patient so that he knows at what level he is doing. Now, when you have pain, can we exercise? Yes, we can exercise. Now, you can see this. So the idea of using a muscle stimulator is that minimum recruitment, and that allow the muscles to fire in a little bit more. And along with this, he is performing his leg extension. Now, if the patient has pain and pain is not allowing him to perform the exercise, you can either use TENS or IFT to allow to suppress that pain and perform the exercise. So this is again a strength training program allowing the muscles to recruit, because this muscle was inhibited on and off. So I'm allowing the scapular muscles to fire in with the electrical stimulator and perform the exercise. Now, isometric exercises or exercises which are generally can be given when there is pain. Now, only thing is, I will recommend is use a force control. That means the amount of force the person is going to use to push the wall also has to be controlled. A lot of the time, patients try to push it too much. That means what? They are trying to generate too much force on the muscle, which will again trigger the pain. So you need to control this force, ask the patient to slightly push. So you can tell them on the grade, first go easy and then try to increase the force. Now, it is not increasing in pain, you can hold on to that force and tell the patient, you can now control your force of the isometric exercise at this force and perform your isometric exercise. So it will not be a contraindication with the amount of pain. So the shoulder patient had told me that my pain is 5. And when he does the isometric, it is not increasing more than 5. He can still perform the exercise because the exercise is not contributing to the pain and aggravating the pain. Now, if you look at the pain score of 7, you can keep your patient's exercise in this zone, which can be a safe zone for exercise. So if the patient says, so my pain is around 3 now, good, keep exercising. Now, active range of motion you do and the pain is only 3, good. Now I want to increase with exercises and add some load. So I'm going to give him probably a 2 kg dumbbell. And he does the exercise, he says, my pain is slightly increased. How much? Sir, it is now around 5. Good. So this is still a safe zone because in my previous slide, you understood that strength training, you need to have effort. And this is the zone where your strength training. So when he is 5 with 2 kg, he can still exercise. Now, as he exercises and completes his 10 reps, he says, okay, good. Now, second set when he does, as he exercises, the pain is increasing and coming closer to 7. So what do? You stop at the number of repetition because you're touching the zone of 7. Any exercise is crossing 7, you stop the exercise at that particular repetition. So always educate the patient to be on the safer zone for exercises. Now this is exercise software what I use. So for prescribing exercises, it uses the body part, what kind of exercise I want, whether sitting, supine, standing. I can use them and it will give me choices of exercise. Now this is not like you select the exercise and then teach the patient. We teach the patient what he can do. Based on that, we select the exercises images. If not, I prepare my own images and add instructions into them. So it becomes like a template of prescription, like how a medicine is prescribed. So the patient can take forward this and I can add up all the required things of how many repetitions, all those things. Now coming on to the range of motion based exercises. Now range of motion based exercises, in this you can see that I'm giving him a shoulder abduction using a Swiss ball. Now the Swiss ball here is used as a assistive devices to eliminate the friction and allow him to do abduction. So this patient does not have a restriction of his range of motion, whereas it is because of the weakness, he is not able to do the range. So I'm using the Swiss ball, gravity eliminated, using less forces and getting the range. Whereas in this image, I'm using a sliding board, doing a shoulder flexion, gravity eliminated, the friction is going to be less, whatever strength is available, he is able to do. So range of motion, when the patient says, I'm not able to do, evaluate the passive range of motion and the active range of motion. So that will also give you an idea to know whether the restriction is because of the joint, or is it because of the muscle stiffness, or is it because of the muscle tightness, or because of the muscle weakness. So based on that, your exercise will change. So this is one of okay, I'm not able to play the video. So this is one of a patient's video, how the range has improved. I'm taking a video and keeping. So when you have a patient who is basically coming to rehab for the range of motion exercises, try to evaluate these patients daily with a goniometer and a video. So goniometric measurement, we will understand better, but a video for a patient, like, okay, see, this is how much you are able to lift. So ideally in this video, this patient will be able to lift it till the shoulder level, and then he is above the shoulder. So this is for the patient to understand that, yes, this is what I am looking at progression. Now for range of motion based exercise, you need to have a weekly approach. That means whatever exercise you are giving, you see whether at the end of the week, is there any changes happening. If there is no change at the end of the week, then you need to change your approach. That means you need to use maybe a different position, maybe use some assisted devices or other possible scenarios to try and change the range of motion. You can't go with the same set of exercises. Then when you start your range of motion, always first try to achieve the functional range. So inform the patient that our aim is first functional. That means where their activity can be done. So shoulder, I would like to look at 120, maybe functional range, full range, our 180. So explain the patient, this is our first target, and then we are going to look at full range. And strength-based exercises can be started at the available range of motion when you start doing. So once you have started with active range of motion, the proprioception or neuromuscular or balance and plyometrics are all going to be a combined package till we reach the functional at the end. So as you start active range of motion, take into consideration the functional range of motion. So start them functional activities. So give them activities what they can use the functional range of motion and start performing daily activities with them. Incorporate both open kinematic as well as closed kinematic chain exercises along with them. Understand the joint stiffness or muscle stiffness, and based on that, start giving them exercises. Your balance and proprioception, first thing you need to have position sense. So see whether they can understand the position, what you need to follow. A lot of the time patients find difficult to know what you are telling them. That means auditory information is not translating into position sense. You can use visual feedback, mirror, all those things. Understand again, the primary thing to improve on these patients is the stability, and then follow by mobility. And the plyometric and sports specific is all the later stages when the strength is good, range is good, only then they are going into those exercises. Now, looking at the effort for exercise, I always tell my patients, do you want an easy exercise or do you want a beneficial exercise? Now, a lot of the time patients try to do an exercise and they see it is difficult to do. so they discontinue it. Let's for example, a person cannot do a push-ups and he ends up not doing the push-up only because he says, oh, it's difficult to do. But the point is we need to do those exercises which is beneficial. So if you look at the exercise effort, earlier we used the scale for the pain. The same thing you can use. You can divide them into easy, slightly difficult, difficult, discomfort, and pain. Now, only if you do the exercise in the zone of from halfway of slightly difficult to halfway of discomfort, there is going to be any benefit in the exercise. This is whether it is in the rehab or in the fitness also. So if the patient is going to do an active range of motion at the range which is already available, then he will be only on this zone and there will be no improvement. If he goes onto that extreme range with a slight push of the tissue tension and feels slightly difficult, that is when the benefit starts setting in. Now, whether it's an isometric exercise or the range of motion exercise, if the patient tries to use too much force and pushes, that is, he is going into the discomfort zone, and after this zone comes the pain zone. So he will end up on being on the pain. So explain the patient that when you do the exercise itself, try to see in which zone you are and try to see that you are on that zone. Now, when you come on to the repetition, I am starting a 5 kg dumbbell and I'm going to do a shoulder flexion. And as I start the exercise, I feel it slightly difficult. Very good. You are going on the good zone. By the time I come on to the third set and I am feeling more discomfort. That means what? You're still on the safe zone, but you're close to going on to the pain. So this patient can continue with the 5 kg, no issues with that. But let's say this patient is now progressing to 6 kg and in the second set, he starts feeling discomfort. So that means the third set, he can go into the zone of pain. So it is better to stick to the 5 kg and be within the zone of exercise. Now, the patient has done 5 days of exercise and with 5 kg, he is in this zone. He's taken a break for the next 2-3 days and he had a very tough day at the office. And when he comes, he knows that 5 kg is what I was doing and he starts at the 5 kg and by the time he finishes the first set, he is feeling difficult to discomfort. That means today the patient is in this zone, so it is not better to start at 5 kg, but better to start at 4 kg because then he will feel it slightly difficult. So the day he starts the exercise also is very important. So you don't need to always start at the same weight what he was doing before. Now, these are exercises, progression options. I love to use the resistance band a lot because that gives me a lot of flexibility in managing my load. So if you see, this is an SLR exercise. So now if I look at the basic principle, this is a hip joint, axis, frontal axis, and using a sagittal plane. Now it is predominantly muscles of quadriceps, which will be used in stability, isometric, which is going to keep the knees locked, and the hip and the rectus femoris, which is a 2-joint muscle, is going to do the muscle action. So rectus femoris is going to have a first order lever, and what I'm going to do initially is tie the band above the knee, so it is still going to be a first order lever and the patient is performing. As the strength improves, I can move the band below the knee, that is at the insertion of the patella, and then go probably to the mid leg and to the foot. The same principle can be used when you do a weight cuff. So when you plan the exercise, at the back of the mind, all the principles has to be kept in mind. Okay, so this is the repetition of the exercises, what I earlier explained you, that when you do the repetitions of the exercises, you need to know heavier load, lower load. So if you are going to use heavier load, you will be more focused on strength. You can have repetitions which can be less than 10 reps, so you will be able to gain strength. But if you're going to do endurance, then you need more repetition, the load can be less, and always try to improve the strength and then progress to the endurance. Okay, this is more of aerobic based exercises. If you have a person who is into hypertension and wants to do walking, so he has to do a little brisk walk to keep up the intensity. Whereas if somebody has to lose weight, they have to have a low intensity, that is longer duration. Okay, this is an example how you can progress the exercises. Now this is a ab crunch I'm giving. So the patient has got the legs lifted up and he's got a Pilates ring over here. So this is open kinematic. Stability has to be maintained by this, and then he's doing the crunches. I am progressing this with a long lever now. So the leverage increases and increases the stability component, and he does the crunches. Now, in this image, I've given him a wedge over here. So that means what? The upper body, I have given him stability as support. But this stability, idea was to improve the stability, but I have challenged the mobility with the. So this is again another variation I'm doing, using the tumbles and using the arm going into a overhead flexion. So whereas this leverage is now increased and challenging the stability of the lumbopelvic hip. Based exercise for the abdominals, where I'm giving him variations with the resistance band, where he has to maintain abduction so that his abductors are isometrically functioning. I'm giving him a medicine ball of 1 kg. So what is happening now is your adductors are working as isometrics, and the weight is adding downward force to make the flexors hold and work more. This is a Pilates ring again, which is going to have abduction added up, and this is Pilates ring adding up adduction inside. So this is to know how you can add up a sports specific training and how frequently you should be adding up. So usually people try and do these kind of trainings at different days and those things. So understand these sports specific trainings are to be added just before the season, only for 2 to 4 times a week. Whereas during a sporting season, that means this guy is playing already in the tournaments every day in and out. So it has to be only 1 day or 2 days for maintenance during the training. It should not be done every day. And when you do some sports specific training, the workout means this is for specifically for speed. It has to be done for 20 seconds and the rest has to be for about 1 minute. And this is how the cycle should be. So the rest and this has to be specifically told to the patient. This is an agility training. So agility training can be based on 20 seconds and 20 seconds. So the rest and the workout duration has to be appropriate. So you don't need too much of rest for that. Plyometrics is the last line of training where you do them when they have full range of motion, flexibility, proprioception. Only then you do, whether it's for upper limb or lower limb. only then they are supposed to be added up. And again, plyometric training are to be added up only 2 sessions in a week, not everyday training. This is how you can make your own clinical evaluation. Now, this is something what I use in my clinical practice, where I just have a body part where to mark where is the area of the pain and what are the joints involved, what are the movements. So I just make a small clinical note. I make a VAS score of the pain, and if I want individual movements pain, I write them, and a quick history where I can write down. So this can be used by anybody, and whatever you are comfortable with, you can make a small document. And I also include a treatment consent form here, because these days with a lot of the medical legal issues, a consent form will legally help you. So you just tell, it mentions that whatever therapy we are going to give has been explained to the patient, and patient is fine with that, so he can just sign them. This is an evaluation I use sometimes for my fitness or for the people whom the mobility based things. So again, I use a chart of body, and I use some functional scoring, which is called as FMS scoring, and I use some basic strength components, and I also make note of what are the muscles I'm evaluating, and seeing whether those muscles are activated, whether the muscles are weak, whether there is tightness, and any particular notes. And this is how I use the software to make an exercise chart with instructions, and additional notes, whatever I want is made and handed over to the patient. This is again a fitness or sports specific evaluation form. So I have about 4 or 5 forms where I can work around my patients. And this also has when I'm supposed to do the re-evaluation for them, and noted down that this gives me a guideline to know whether they are progressing properly. So the general take-home message is, again, remember there is no good or bad exercise. Only thing is you need to know how you select your exercise and plan ahead. Always it is better to educate the patient on your plan. So if the patient has come with pain, you can give them a guideline telling, okay, first our exercises are based on pain. Then you are going on to restoring the range of motion. And if there is any trick movements, you're going to try and work on them, and then progress to the strengthening. So the patient knows his roadmap, what your sessions are going to be. Make sure you assess periodically. So during the pain, you need to assess maybe every day. When you're doing every range of motion, it has to be every week. And then you need to know from what plan you have changed to improve them. And for strength-based assessment, remember that strength-based, you need to change exercise only after 6 weeks to 2 months. Now, whatever exercise benefit they get in the first 2 weeks is more on neural adaptation. So the exercises in fitness has to be changed only after 6 weeks. Always tell the patient the quality of the movement is very important. Repetitions is secondary, because a lot of the time patient, the moment you teach exercise, they want to know how many times I need to do. So tell them it is just about the quality, and the reps is secondary. Go from individual muscles to functional. Use assistive devices as and when that is required, and explore for various forms to break pattern of exercises, so that you can do from different positions, and understand the global concept of the body and progress the exercises accordingly. So this is roughly what I can give from the clinical perspective of how to plan the exercises. Now I'm open for questions. Himanshu?
Hello, sir. Am I audible? This is Harsh Rasdeep.
Yes, Harsh.
Sir, we are getting a positive feedback regarding your session, and there are a few questions. If you permit, can I narrate for you?
Yes.
Sir, someone is asking, sir, please repeat the stability versus mobility concept which you explained.
Okay. Can I put that slide again? Himanshu?
Himanshu, sir?
Sir, just a minute, sir. Just a minute. Now try now, sir. You are the
Okay.
host.
Just a second. I'm trying to open that slide again. So I can share it now.
Yes, sir. Yes, sir.
Okay. Can you see the slide?
Yes, it is
Can
visible,
you,
sir.
it is visible, right?
Yes, sir.
Yes, sir.
Okay. Now, remember, now this guy is doing an exercise. Okay. Now, everybody knows that he's doing it for the left hip. Now, you can tell that, sir, he is doing strengthening for his gluteus maximus on the left side, or I can tell that he is doing gluteus maximus for the right side. Now, let's say an example. My patient says, sir, I get a back pain or hip pain when I stand and work for 10 minutes also. There's another patient who says, sir, I get pain when I walk for 100 meters. Okay, both the patients' pain is around the same area. The person who says, I stand and work and I get pain is probably the stability strength component is less. That means what? When you stand, you are standing still and this strength is poor. Walking is mobility. I walk, I get pain. Okay. So to understand, that is what I said. Your stability versus mobility is if I have to improve the stability component. That means I have to improve the stability component of this leg, that's the right leg, by moving the left leg. Why? This is the flag post and this is the guy who is pushing. So when I move the leg on this side, the right hip is working more isometrically to be stable. So that's the workout how it gets, and it improves the strength component. So we need to identify our patient whether he needs stability based strengthening or mobility based strengthening. I hope it sort of clears the doubt.
Yes, sir. Thank you, sir. Thank you very much. Uh, we get the answer now. I think there is a few more queries. Should I narrate for you, sir?
Yeah,
Till the Harsh sir is not available. Yeah.
Yeah, there is one question. What basics to decide repetition for individuals?
Yes, sir.
Okay, now remember in repetitions, to keep it very simple, whatever repetitions you want, that means first thing is the repetition is based on what you want to achieve, whether you want to achieve quality of movement or you want to achieve range of motion, you want to achieve flexibility, strength, endurance. Okay, so you decide first what you want to achieve. Based on that is your repetition going to do. Now, if I want to improve quality of movement, that means what? This guy is doing a shoulder elevation every time with the shoulder movement. So the repetition will be repeatedly doing every half an hour, 1 hour. Why? so that he remembers that, okay, I should not do like this, I should do this. It can be 4 or 5 repetitions, that is enough. Now, if I want to improve range of motion, every 1 hour or 2 hour, try to do the movement 10 repetitions, 2 sets maybe, to get that flexibility on the tissues.
So no,
okay, it can be 2 sets. Now, if I want to improve flexibility by stretching the muscle, whenever you stretch and finish, do an active lengthening. That means what? If I'm going to stretch my biceps with a stretching, after that, active lengthening. It's an active lengthening. You can do just 4 or 5 repetitions. So only thing is I want the neural component to kick in. That's enough. When you want to do strength training, once a day is enough. You need to do minimum 6 repetition to 10 repetition. So today, if I'm doing with 5 kg my weights, 6 repetition, I feel discomfort. 6 is good. 2 weeks down the line, you will be able to do 8 repetition. And when you achieve 10 repetition, and now you feel it is easier, that means what? You are able to feel it very easy. You need to go back again to increase the weight, again 6 to 10. Endurance, you go up to 12 repetitions. Now, research has proven that more than 12 repetitions is not so beneficial. Okay, so 6 repetition is the minimum that is recommended. So from 6 to 12 is more than sufficient in terms of repetition when you do strength training. I hope that answers your question.
So there is one more query.
Yeah. Yes.
Sir, someone is asking, sir, can you share the name of any software which can be used for exercise prescription?
See, Exercise Pro is one exercise software what I use. It's an online based also. You have which you just subscribe, pay money, and then get it. There is something called EndoRush. It's an app based software which is made by a physiotherapist based in Bangalore. It's a beautiful app. You just subscribe, patient downloads it, and whenever the patient does the exercise, they can send you a notification and you will know that the patient has done the exercise. You can also score the pain in that. That's a beautiful one. There are some MyPal Fitness for a little bit of gym-based exercises. So these are some of the things which I found quite easy to use and simplified way of using. Okay, there is some question
Okay,
on
sir.
stroke rehab.
Yes, sir.
So sorry guys, stroke is not my main area, so I will not be able to give you much. But when I deal with my stroke patients, what I do is more of functional training for them. So whatever pattern of exercise they are doing, I give them a target base. So if there is a circumduction gait, I use like the Frenkel's method. Okay, let's try and reach over here. So a lot of feedback, and maybe sometimes I use a resistance band to control the pattern and try do a functional training. That works for me, so I stick to that. Can you explain plyometric training? So Radhika is asked about plyometric training. Plyometric training, it's a big area what I can tell, but remember plyometric training is only for people who are looking at explosive activity. So if people are going to do sports, only for them. And if you have to give them plyometric training, simple rule, they should be able to do a squat if it is for lower limb without any discomfort. They should be able to do a single leg squat without any difficulty. They should have good range. Only then you progress. You can have grades of plyometric, making them do a small hop. So this is how I do, make them do small hops and then progress to moderate hops. That means what? You make them jump little more further and then go on to full explosive. Now again, plyometric exercises should not be more than 20 minutes. And it should be at initially about 70% of his capacity of jumping, go up to 90%, and one day after he has improved, go him all full throttle. Rehab for sports athletes and non-athletes. What would be rehab program? Samuel Benjamin. Okay. See, everybody's body is the same. If my bone breaks, it will take 6 weeks to 8 weeks to heal. Even for an athlete, it is going to take the same period. The only thing is the conditioning of the soft tissue and the requirement. So if you're looking at a sports athlete rehab, immobilization of the particular part has to be stopped. So if you see for our operated patients on the knee, on the second day itself, we start them with upper body cardiovascular exercise so that we don't allow the deconditioning. So only these are the changes what you will be doing in the exercise rehab for them. Samuel Benjamin has got a question. I'm seeing a patient who is a policeman. He is very flexible and strong, but his knee is damaged, ACL, PCL tear, but he is feeling pain and does all exercise. Yes, Samuel, ACL and PCL, they can have damage, but if they have good muscle control, we call them copers. In my previous ACL rehab, I mentioned that if they have a good muscle control and there is no instability, you can continue their exercises. Maybe they will need a surgical intervention only if they start feeling instability. Anjali Batra wants to know open kinematic and closed chain exercise. Okay, now open kinematic chain is more of our lower limb body function. Upper body is more open kinematic. So if I have anybody who is having a lower limb problem, it can be a hip replacement, hip impingement pain, bursitis, or a knee pain, ankle sprain, instability, any of these patients, I will always know that I need to do more of closed kinematic chain rehab. If it is an upper limb, I need to know it is going to be open kinematic chain rehab. Now, the patient has got poor quadriceps or a ONE patient, the quadriceps is weak. To improve the strength, I need open kinematic. That is going to have load on the muscle, improve the strength. Now, I know that she's developed a baseline of strength. Now, I need to translate this to functional. So, I will progress that lady into squatting exercise, which will be chair, sit to stand, or stair up and down, which is a closed kinematic based exercise. So, whatever strength on quadriceps I improve, I will use it functionally on sit to stand or climbing up the stairs to help them in closed kinematic chain exercise. For the shoulder, maybe I can use the closed kinematic using a weight bearing quadruped position, and then functionally go on to lifting the weights on the shoulder, which will be open kinematic. So your rehab goal has to be that I need to incorporate both closed kinematic and open kinematic to the advantage of the present condition and progress accordingly. Sir, can you give an example of stability that we will perform on patients opposite leg? Now, can you give an example of mobility exercise? Mobility exercise is like what I said, you need to improve your shoulder deltoid. So what do you want to do? Just do abduction exercises with weights. So that is your mobility exercises. If I want to improve stability of the shoulder, that means what? You need to more require the cuff. So I would like to have the cuff strengthened, followed by when you do my mobility. So these are your patients who are going into that elevation. That means what? The stability is not there. So you need to work on that. Fahim has asked me a question. In your experience in exercise prescription, how do you select the appropriate ball or tube or the band? Okay, good question, Fahim. I wanted to mention that. If you remember, the resistance band has got various levels. So, okay. Now, what I do is I always try to use the maximum resistance what I can use. So if I'm going to do an SLR for my patient, and I always use the highest resistance, but I use the leverage as the component. So when I do an SLR, I use the above knee band with a high resistance, so the patient can progress with that slowly down. Now, if I give a low resistance on the foot, after 2 weeks or 1 month, he is improved the strength. Now I need to buy another band. So I use that component to change the band. So that is one. The ball, how I decide is, general Indian population 65 or 55 is sufficient enough. We fit more into those category. So that is good enough to use for our patients. So that's about the questions what I can see in the chat box.
Yes, sir. Most of the questions you have answered, sir, very well. And everybody is appreciating, sir, for clarifying the doubts. So I think it's all doubts have been cleared, sir.
Yes.
Thanks a lot again.
Yeah, thank you. Thank you,
Thanks
Himanshu. Thank you, Harsh.
And sir, it's good to see many attendees attending your session again today. We have Dr.
Yes.
Jabin, sir, as you mentioned. He's principal at Choitram College, Indore. We have Dr. Amita Anup Sharma. You know her very well. She was joining from Dubai.
Yes.
Dr. Ramakrishna, sir, also. He's there in your session. He's also appreciating. And to all the attendees, tomorrow also we have a session at around 8:30 p.m. in the evening. And that would be on a topic which is also not very much covered. It is like how aerobic exercises can do wonders in medical conditions. So that will be taken by Dr. Mrinal Mahajan. He is the director of Nerve Physiotherapy and Rehabilitation Center. He'll be taking it tomorrow 8:30 p.m. Meanwhile, thanks a lot to all of you, and heartiest gratitude to K. Ganesan, sir, for sparing his valuable time and giving us the knowledge again. On the forum, sir. Thanks a lot.
Thank you, everyone, and stay safe. There's Fahim also. He's a physiotherapist from Maldives. Nice to see him. Manisha also.
Okay, sir.
From Bangalore. So it's nice to have all of you here for the session. So stay safe. Thanks, Harsh. Thanks, Himanshu. Thanks, Deban.
Thank you.
Thank you, everyone.
Thank you, sir. Thanks a lot. Thanks to all of you for being here. We'll meet tomorrow surely. I think Dr. Himanshu, you can end the meeting. Thanks to all of you. Thank you.